What if the greatest benefit of a weight loss medication is not simply the number of kilograms you lose, but the opportunity it gives you to build a completely different way of living? For many people, these medications reduce persistent hunger, increase fullness, decrease food cravings, and make weight loss possible after years of struggling. But there is an important truth we need to understand. Medication can reduce the biological pressure to eat, but medication alone may not teach you how to choose food, prepare meals, manage stress, protect your muscles, organize your environment, or respond when old habits return. For sustainable weight management, we need both biology and behavior. We need medical treatment when clinically appropriate, but we also need lifestyle intervention, health literacy, practical dietary skills, and enough time for healthier patterns to become more automatic. Obesity is not simply a failure of willpower. Obesity is a chronic, complex, and relapsing disease. It is influenced by genetics, hormones, sleep, medications, stress, mental health, the food environment, socioeconomic conditions, physical activity, and learned behavioral patterns. When a person loses weight, the body may respond defensively. Hunger can increase, fullness signals may weaken, and energy expenditure may decline. This biological adaptation helps explain why maintaining weight loss is often harder than initially losing it. Medications can help counter some of these forces. They act on pathways involved in appetite, satiety, glucose regulation, and food-related reward. Many patients describe a reduction in what is sometimes called food noise, the constant mental preoccupation with eating. This reduction in hunger is not cheating. It is not weakness. It is a therapeutic effect that may allow a person to make healthier decisions without battling intense biological hunger every hour of the day. The World Health Organization now recognizes GLP-1 therapies as part of long-term, comprehensive obesity care, not as isolated injections, but alongside structured support for healthy eating, physical activity, behavior change, and continued follow-up. Medication creates an opportunity, but skills determine how that opportunity is used. Imagine that someone has spent years driving on the same road. Every evening after work, stress triggers a stop at a fast food restaurant. Every television program is paired with snacking. Every celebration revolves around oversized portions. These behaviors eventually become automatic. Then a GLP-1 medication reduces appetite. Suddenly, that person is no longer thinking about food constantly. Portions become smaller. Cravings may become quieter. This creates a window of opportunity. But if the person continues buying the same foods, keeps no healthy meals at home, remains sedentary, sleeps 5 hours a night, and has no strategy for emotional eating, the original behavioral pathways remain largely intact. The medication may have quieted the signal, but it has not necessarily replaced the routine. This is why GLP-1 treatment should ideally be viewed as a therapeutic learning period, a time to practice the behaviors that will protect health during treatment and support long-term weight management. Most patients already know the general advice: eat healthier, exercise more, control your portions, avoid processed food. The problem is that information alone rarely produces lasting behavior change. Sustainable change requires translating general recommendations into specific actions. What will I eat for breakfast tomorrow? What can I prepare when I arrive home exhausted? How will I respond when I am stressed but not physically hungry? What will I order when eating outside? How will I continue exercising when it rains, when I travel, or when my schedule changes? Behavioral weight management programs can help people develop these solutions through goal setting, self-monitoring, problem solving, feedback, relapse planning, social support, and adjustments to their physical environment. Reviews consistently show that behavioral interventions remain valuable components of obesity treatment, including among people with more severe or complex obesity. Instead of saying, "I need to eat better," a person might create a concrete plan. On Sunday, I will prepare brown rice, beans, chopped vegetables, and a healthy sauce for 3 workday meals. After breakfast on Monday, Wednesday, and Friday, I will perform 20 minutes of resistance exercise. Specific behaviors can be repeated, vague intentions cannot. Repetition changes the brain. Neuroplasticity refers to the brain's capacity to adapt through experience and repeated practice. Every time we perform a behavior in response to a familiar cue, the brain learns. Repeated patterns can gradually shift from deliberate decisions to more automatic habits. This applies to unhealthy behaviors, but it also applies to healthy ones. A person may initially need significant effort to prepare vegetables, eat slowly, walk after dinner, or stop eating while watching television. With consistent repetition in a stable context, these actions can become easier and require less conscious effort. Habit formation is not instantaneous, and there is no scientifically valid rule that every habit forms in exactly 21 days. The time required varies according to the person, the behavior, the environment, and how consistently it is repeated. However, research supports the use of habit-based strategies as a promising component of weight loss maintenance. This is where GLP-1 therapy may offer a unique behavioral opportunity. When hunger and cravings are less intense, a patient may have more mental space to rehearse new responses. When I am stressed, I walk for 10 minutes instead of eating automatically. When I enter the grocery store, I begin in the produce section. When I prepare dinner, vegetables and fiber-rich foods occupy most of the plate. When I want a snack, I first ask whether I am physically hungry, emotionally distressed, thirsty, tired, or simply responding to a cue. The goal is not to create a perfect brain that never wants highly palatable food. The goal is to strengthen healthier pathways so they become easier to access, especially during difficult moments. Health literacy is a weight management skill. Health literacy is not simply the ability to read. It is the ability to find, understand, evaluate, and use health information to make appropriate decisions. Nutrition literacy and food literacy go further. They include the ability to interpret food labels, understand portion sizes, plan balanced meals, assess nutrition claims, budget for healthy food, store ingredients safely, and prepare meals in a realistic way. This is especially important in the GLP-1 era because patients are surrounded by confusing and often contradictory advice. One source says to eliminate all carbohydrates. Another says to drink most meals as protein shakes. Another promotes fasting despite severe nausea or poor intake. Social media may present highly processed products as healthy because they are labeled low-carb, high-protein, natural, or sugar-free. Without adequate health literacy, a person may lose weight while still developing a nutritionally poor eating pattern. Current evidence indicates that health literacy, food literacy, and nutrition literacy are interconnected and can influence dietary choices and health outcomes. Effective interventions must also consider culture, food access, income, and the realities of the person's living environment. A good lifestyle program should therefore teach patients how to ask, what evidence supports this claim? Is this product genuinely nutritious, or is it only being marketed effectively? Can I sustain this way of eating for several years? Does it provide enough protein, fiber, vitamins, minerals, and healthy fats? Is it appropriate for my medical conditions and medications? Am I learning a skill or becoming dependent on another commercial product? Dietary skills protect nutrition. GLP-1 medications often cause people to eat substantially less. This can be beneficial, but reduced food intake also means that the nutritional quality of every meal becomes more important. A patient who previously ate 3 large meals may now tolerate only small portions. If those portions consist mainly of pastries, refined snacks, or nutritionally incomplete meal replacements, the person may consume inadequate protein, fiber, micronutrients, and fluids. This is why patients need practical dietary skills. They need to know how to construct a small but nourishing meal. For example, a meal may include a protein-rich food such as beans, lentils, tofu, fish, eggs, unsweetened yogurt, or another appropriate protein source, fiber-rich vegetables or fruits, a minimally processed carbohydrate such as oats, brown rice, corn, root crops, or whole grains, and a modest amount of healthy fat from nuts, seeds, avocado, or other appropriate sources. Food preparation skills are equally important. Patients should learn several simple meals that can be prepared even when time, energy, or appetite is limited. This could mean vegetable and bean soup, overnight oats with fruit and seeds, tofu with mixed vegetables, a lentil bowl, or a simple fish and vegetable meal. The best dietary pattern is not merely the one that produces rapid weight loss. It is the one that is nutritionally adequate, culturally acceptable, affordable, enjoyable, medically appropriate, and repeatable. Sustainable weight loss is not only about reducing body weight, it is also about preserving strength, mobility, metabolic health, and independence. That's why weight loss must protect muscle. During any significant weight loss, whether produced through lifestyle intervention, medication, or surgery, some lean tissue may be lost along with fat. GLP-1 treatments generally reduce substantial amounts of body fat, including visceral fat, but reductions in lean mass can also occur. This makes resistance training and adequate nutrition essential. Muscle is metabolically important. It supports glucose regulation, physical function, balance, bone health, and the ability to remain active. Patients using GLP-1 medications should therefore not evaluate success using the weighing scale alone. Progress may also include a smaller waist circumference, improved blood pressure or glucose levels, greater strength, better mobility, improved sleep, increased physical endurance, preserved or improved muscle function, and a healthier relationship with food. Evidence increasingly supports combining GLP-1 therapy with progressive resistance exercise, appropriate protein intake, dietary fiber, hydration, and monitoring for inadequate intake or excessive loss of lean tissue, especially in older adults and people at risk for frailty or sarcopenia. Protein requirements must be individualized, particularly for patients with chronic kidney disease, liver disease, or other medical conditions. More protein is not automatically better, and patients should avoid adopting extreme high protein diets without appropriate clinical assessment. One of the common questions asked is, what happens when medication is stopped? This is one of the most important conversations to have before beginning treatment. In the Step 1 extension study, participants who stopped semaglutide regained approximately two-thirds of their previous weight loss over the following year, with some cardiometabolic improvements also moving back toward baseline. Similarly, in the SURMOUNT-4 trial, discontinuing tirzepatide was followed by substantial weight regain in many participants, while continued treatment was associated with better maintenance and additional weight reduction. This does not mean these medications have failed. When blood pressure rises after stopping an antihypertensive medication, we do not conclude that the medication was useless. We recognize that the underlying condition may still require treatment. Obesity may also require long-term therapy. Lifestyle change cannot guarantee that weight will never return after medication withdrawal. It would be misleading to tell patients that enough discipline will completely overcome powerful biological adaptations. However, lifestyle intervention remains essential whether medication is continued, reduced, changed, or stopped. It improves diet quality, fitness, strength, sleep, functioning, self-efficacy, and cardiometabolic health. It also gives the patient practical tools for responding to increasing hunger, disrupted routines, travel, stress, illness, or changes in treatment access. Medication and lifestyle intervention should not be positioned as competitors. They solve different parts of the problem. To build a sustainable treatment plan, a combined GLP-1 and lifestyle program should answer 5 questions. First, what behaviors are practiced while appetite is better controlled? Second, are we improving the patient's health literacy and ability to evaluate nutrition information? Third, can the patient shop, plan, and prepare several healthy meals independently? Fourth, are we preserving muscle through resistance exercise, adequate nutrition, and appropriate monitoring? And fifth, what is the long-term plan if the medication becomes unavailable, ineffective, unaffordable, poorly tolerated, or no longer clinically appropriate? The answers should be developed collaboratively with a healthcare team. For some patients, long-term medication may be appropriate. For others, treatment may need modification because of adverse effects, pregnancy plans, medical contraindications, limited access, or personal preferences. Medication should not be started, increased, tapered, or stopped without appropriate clinical supervision. In summary, GLP-1 medications can be powerful tools. They can reduce hunger, improve metabolic health, and help patients achieve weight loss that once felt impossible. But the most sustainable treatment does more than make the patient smaller. It makes the patient more capable of understanding health information, capable of preparing nourishing food, capable of recognizing hunger and emotional triggers, capable of building strength, capable of redesigning the home and work environment, capable of recovering after a difficult week without declaring the entire effort a failure. The medication may turn down the biological volume. Lifestyle intervention teaches the patient what to do in the quiet. If you believe you need more structured support while taking a GLP-1 medication, ask your endocrinologist for a referral to a lifestyle medicine specialist. An intensive lifestyle medicine program can help you build sustainable eating patterns, preserve muscle, improve fitness and sleep, strengthen behavior change skills, and prepare for long-term weight management, whether the medication is continued, adjusted, or eventually discontinued.